Dr. Gudin, can you describe limited options regarding the use of pain relief drugs such as opioids and side effects and the risk of addiction?
You know, one of the challenges with pain treatment today, and not just today, probably for millennium, is that we're very limited in our options for pain treatment. We have the typical over-the-counter medications like acetaminophen and NSAIDs, and most people take those without really understanding the risks of those medications. And I'll tell you, surprisingly, patients take them even though they fail to get benefit from those medicines. So it's almost like a double-edged sword. They're not really working well, but they're also subjecting themselves to certain toxicities. And what I've recognized as a clinician, as someone who treats pain, is that our prescription options are almost as limited. We have some non-opioid choices. We have some what we call adjuvant medications like the anticonvulsant drugs, the antidepressant drugs, which treat certain types of pain. And then we have opioid and opioid-like therapies. So not a whole lot of choices. And usually what pain management clinicians do is rotate or juggle between the available options, and we combine that with non-pharmacotherapy, like behavioral modalities, physical and occupational therapies, counseling, which is very important. Most people, it's underrated just how effective these non-pharmacological strategies can be. Guided imagery, meditation, cognitive behavioral therapies. When it comes to the medications that we use to treat pain, just thinking out loud, I don't think there's a single one that's devoid of side effects. Every single medicine that we use has a side effect profile that we explain to patients. And that includes the class of medicines which have gotten a really bad rap called the opioid analgesics. Now granted, I think we kind of overdid it a little bit in trying to be good to our patients with using a class of drugs like opioids. And we learned a very hard and difficult lesson that there are some patients who just aren't good candidates for that class of therapy. Because although they're really a good class of medicines, they're a bad class of drugs for patients who can't control the use of their medications. And those patients go on to develop substance use, or what we call OUD, opioid use disorders. And we have more effective treatments for those, but once it happens, once that cat is out of the bag, it's a very difficult situation to control. So what we try to do as clinicians is maximize every possible therapy before we get to an opioid. And if and when we decide that a patient has failed physical therapies, non-pharmacological therapies, non-opioid therapies, interventional therapies, things like injections or implanted devices for pain, spinal cord stimulators and implanted pain pumps, we have all these novel technologies. And if patients have failed even things like surgery, we will consider a trial of opioid analgesics. And it's important for clinicians to recognize that when opioids are given, they're given as a trial. So if the patient responds well, and they're a responsible opioid taker, and they're not running out of medicines early, and their prescription drug monitoring database queries come back that there's only one prescriber, one pharmacy, they're not doctor shopping or pharmacy shopping, and that their urine drug screens come back that there's nothing that doesn't belong in their system, like any type of illicit drugs, and they're not, using alcohol or other substances that we wouldn't want to combine with our central nervous system depressant medicines, then that patient might be a good candidate for opioids long-term if they're getting significant relief and improvement in function. But that doesn't happen for all patients. For some patients, they continually dose escalate despite not having any real benefit from the medications. And for those patients, we need to have a heart-to-heart discussion that, look, this probably isn't the right class of medications for you. Let's kind of go back to the drawing board and see what we could devise as a regimen that might actually be effective for you.
While the scientific research community has been able to identify many nociceptive targets as well as ligands that bind to them, surprisingly, only a few molecules eventually become FDA-approved for treatment use. Can you discuss some of the limitations to developing effective analgesics that eventually reach FDA approval?
As a pain clinician and an academician and a researcher, I've been intimately involved with the development of a number of analgesic medications over the past few decades. And I'll tell you, it's a challenging space. The way that clinical trials are designed is to compare a drug versus placebo. And believe it or not, placebo is very difficult to beat. Because our medications are only partially effective, patients might only get 30, 40, 50% relief from any particular compound that's in development or any compound that's on the market. Placebo has a 30 to 40% responder rate. If patients come to a clinical trial unit and someone in a white coat has them sign a bunch of papers and gives them a pill that's, even though it's placebo, they get some benefit from that. And it's hard in clinical trials for the active drug, the drug that's being studied, to actually beat placebo. So many medications historically have not come to market because they haven't been able to beat placebo. And that's one of the kind of travesties of the world of analgesic clinical trials. So if a drug makes it to market, rest assured that the trials have shown that it clearly beats placebo. Now, one of the things we look at are what are the drugs that have failed and what are the drugs that are up and coming that we may actually have in the future. And it's a really exciting time for pain medications because we've uncovered these novel mechanisms of action, these novel pain pathways that traverse our peripheral and central nervous system. And the brilliant scientists, knock on wood, have developed targets or molecules that bind to these receptors and activate the receptors. And although there are some non-opioid products in development, ion channel, like sodium channel inhibitors, which we may actually see in the near future, there's also a lot of research going on to see, can we develop an opioid-like molecule which would give us the analgesic benefits, the pain relief that we might see with an opioid, but take away the baggage, take away the side effects that are associated with opioids. Not just the bothersome side effects like nausea and sweating and constipation, but the dangerous side effects, respiratory depression, likability leading to addiction and overdose. And there are a few companies that have actually made headway there. We're seeing these new chemicals that can either deter abuse or bind to receptors that take away the likability and take away the respiratory effects of the opioids. So I think it's an exciting time. In decades to come, we're going to have pain medicines that are effective like the opioids, but not dangerous like the opioids can be.